Hi everyone, welcome. Thank you so much for being here. Thank you for your patience as we dealt with some technological issues. I'm Dr. Jenn Keller. I'm here, and on behalf of Fullscript, we're so excited to welcome Dr. Aviva Romm back for part 2 of our Women's Health series. And today we'll be discussing fertility, pregnancy, and childbirth, a review of unique challenges and solutions in an era of change. If you did not get to see the part 1 where we talked about advocacy and accessible medicine in women's health, that is available at fullscript.ca/webinar. So please go and check that one out if you haven't yet. Dr. Aviva, thank you so much for being here. It's so lovely to have you. I don't have your bio in front of me, and we're just gonna go.
Let's do it.
We're just gonna go because there's way more fun, so much good stuff to talk about in this, and last time we went way over, and today we cannot.
And we had technological challenges. So anyone who doesn't know who I am, you can read my bio from last time.
I swallowed a bug just before we started, so so forgive me if I continue to cough throughout this.
Keeping it real here.
Yeah. Okay, so the one thing I will say to everybody who doesn't know is, Dr. Aviva is, not only she an MD, but she's also a midwife and really passionate about birth advocacy in this space. And she launched this really awesome free Facebook group called I Deserve Birth Support from a lot of the changes that started happening to the birthing people's rights when COVID started, and it's sort of continued into this space now. So Dr. Aviva, I was wondering if you could just start with kind of explaining what changed, what really kind of radically shifted in this space to sort of preempt a whole bunch of this conversation and the work that you're doing right now.
Yeah, so the things that have been kind of wrong with the obstetric system have been wrong for a long time, and quite frankly, I think what changed is a lot of white women were suddenly being told in New York that they had to go into the hospital and birth alone, no partner, no doula. So a smart doula in New York decided to start a change.org campaign, and in a week got about 500,000 signatures on that. That led to growing attention to the infringement on women's rights that was happening as a result of COVID. And to step back, I mean, this was happening back in end of March, and nobody knew what was going on. So it's understandable that the hospitals and physicians and nurses and nurse midwives wanted to limit their exposure to unnecessary people in the birthing room and limit their exposure to COVID. But they were defining partners and doulas as unnecessary people. And we know from a long history, at least 40 years of studies now, more than that really, that having a person with you as a birthing person really mitigates your risks of not only interventions, but cesarean section. And then when you extrapolate, even though initially it really was affecting a population that gets more attention when we speak up, the reality was that the risk of impact for Black, Indigenous women of color, people of color birthing was going to be even exponentially more, because these folks are already at high risk of mistreatment, abuse, higher maternal mortality rate, morbidity rate, infant mortality, morbidity. So it became kind of a moment where the restrictions that were happening in New York became kind of a catalyst to shine a light on issues that have been happening for far too long. And so I got involved with, I was talking with this woman who had just started working with me. This poor woman came on and just was like, all right, she's a young mom. She lives in Puerto Rico. She came on to help me with some team management and all that, kind of grow my team. And we're hitting the ground running. We're starting this. So we're on the phone, and I said, I think we need to do something like a hashtag. And so we created this hashtag one night. I was like, I think it should be I deserve birth support, or all women deserve birth support, or all people deserve birth support. And it started out as no woman should have to birth alone. And really we meant no people, but we thought no woman would have a more emotional impact. So it started out, no woman should have to birth alone, hashtag I deserve birth support. And we just started asking people to share their birth stories, share their pregnancy experiences on an Instagram page. And quickly, it became really evident to me that there was a great need for support right now in that moment, and still is, women who were facing uncertainty about how they were going to birth. Someone asked me at the beginning of COVID what I thought the two biggest businesses were going to be for women in COVID, and I said home birth and do-it-yourself hair color. Like, I figured that was gonna, that was going to be it.
Or
And
just haircuts in general, but yes.
yeah, right. Dog haircuts has been a big one too in our house. Dog haircuts, dogs. But seriously, there has been a massive increase in home birth. Women who were scared to go to the hospital. Women whose prenatal care was changing, where they're not going to the midwife or doctor's office anymore and having big medical issues missed. And then again, every time you look at a risk for a white woman, you can double, triple, or more. And New York, sometimes in some places in New York, 12 times the risk of something getting missed or an adverse outcome for Black, Indigenous women, people of color. So I jumped right in and just did what I do, which is create content, and basically just kind of drew deep on the well of 36 years of experience as a midwife, physician, and just started basically talking every week. We started with birth because that seemed to be the most urgent issue. Then we went into postpartum care. Then we swung back around to prenatal care and ended up creating, I think it's like 14 about hour-and-a-half classes. And then we do a weekly ongoing support group. And we cover everything from how to pick a midwife, should you have a home birth, is it right for you, birthing center, hospital, to what to do for group B strep, to a funky video of me and my husband demonstrating how to use a birthing ball in labor. Favorite. Yeah. Oh, you watch it. I mean, I'm not pregnant. I'm 54. Thank goodness I'm not pregnant. And my husband, I mean, our youngest is 26, but we were sheltering in place. So we got my exercise ball and basically just did a bunch of videos on all kinds of how to use a birthing ball, how to use a rebozo, how to, squatting, back massage. It's pretty funny. So
yeah.
Well, and that's what we've been doing.
Which is amazing, right? And I mean, if you haven't seen this Facebook page, I really encourage you to go, because it's not only just how much content you've created in a very short period of time, it's amazing, but the response that you're getting from people
it's
is incredible. Like it's the support, and then like pictures of all the babies being born with the support that they feel that they've gained through this platform, again, just goes to speak to the power of community and the power of the online space that can
absolutely be there. Absolutely. I mean, the group process is far and above anything, and we talked about this a little bit last time, it's far and above anything that any one of us can create on our own. And I remember there was this one day in June, I think it was like June 23rd actually, where people were writing and there were like 10 babies born, and there were these baby pictures, and there were a lot of women saying things like, I would never have had a home birth if it weren't for this group and the support and the education. And then also we had a woman who had a pregnancy loss, I mean a stillbirth at term. We've had women who have had miscarriages. We've had women who have had complicated births. A woman wrote to me the other day, she said, I need to be induced, my blood pressure is high, but I feel so supported and much less scared. And so it's been, there's not been an ulterior motive of like home birth with a midwife and breastfeeding and doing natural. If that's what works for you, great. But it's really been about knowing what is and isn't needed, how to get that information, and how to advocate for yourself so that whatever you go through, you come out of it feeling really strong. There's like 6,300 women on that page now. It's really been phenomenal. So for those of you who are, in the space watching us, if you don't do prenatal work, postpartum work, obstetric work, send mamas to the hashtag page. It's free. We are going to turn it into a membership program at some point in the fall, not so much to monetize the program, but to get more paid support to run the program. Because I've got graduates of my Women's Integrative Functional Medicine program who are nurse midwives, nurse practitioners, lactation consultants, other health providers who are jumping in and providing support at the support group. And we have pediatrics in there too. So it's really beautiful.
And it really shows how much power there is in knowledge. Like when you don't know something, that's what I find, like when I'm so I'm a doula. So when I'm at births, when I try to think of every single thing I can educate on before they get there, so that the words aren't scary.
Yeah.
And that's that's the empowerment process for people. And I don't know, I'm not totally familiar with how care is slightly different for midwives in the States versus with an OB, but in at least in Ontario, your prenatal appointments are like an hour long.
Yeah.
They go through every single possible scenario, so that and their whole premise is informed consent, so that if the moment comes, then you have the ability to make that informed consent choice, which is very different than the obstetrical care that you receive. So you don't often get that information until you're in the space, and then you're just really scared.
Yeah. Here
And
in
so
the
we,
States, we have a much more disjointed midwifery model here.
yeah,
You guys have a government sanctioned, very well supported educational system for midwives, direct entry midwives. Here we have lots of different tiers. So we have the
right,
certified nurse midwife who may practice at home, may practice in a birthing center, may practice in hospital, and her care will depend on the environment that she's in. I mean, her internal care and her love isn't going to depend on that, but whether she has 20 minutes or an hour is going to depend on the setting that she's in, and even how her care manifests will depend on the practice that she's working in and the pressures that are on her. So there's, I think, a little bit less autonomy for midwives working in conventional settings here. And then, of course, there are direct entry midwives who are not licensed or certified, or not, I should say, not licensed or certified as certified nurse midwives, who may be certified professional midwives, or who may be trained in other ways with no formal title or formal credential, but who may provide excellent care, or any of all who may provide excellent care, or any of all who may not.
yeah,
But the problem is access here. So we have like Georgia is the state with one of the worst infant and maternal mortality rates in the United States. They have 11 counties with no OBs, no hospitals, no midwives.
oh my
And
gosh,
so we have huge access to care issues here. The many, several thousand direct entry midwives who are not certified nurse midwives in the US, may not be licensed, which means that parents who are using them, mamas who want to use them, have to pay out of pocket, and that might not be at all accessible. So
yeah.
there are a lot of barriers to care, even when the care is there. And some of those barriers are enforced by the medical model and legal sanction, and some of those barriers are economic, even when the licensure is there. It's very challenging.
So then the majority of the women or birthing people in the United States are more likely to be under obstetrical care.
Yeah, yeah.
Yeah.
We have, I don't know what the numbers are now. I mean, we have like a total of, I think, maybe 10,000 midwives in the US. It's not that many with
Yeah.
home and with CNMs, and it may be more now, but it's around that. And until recently, like very recently, less than 2% of births were planned home births. So it's really been really small. And even with the increase that we're having now, it's still going to be a marginal number. And most care is obstetric care. Or if it's with a nurse midwife, it's still within the realm of obstetric care, because most states that allow even nurse midwives to do so at home only allow midwives to do so with the backup of an OB. And if an OB isn't going to do it, then that limits the access as well. And even in the hospitals, midwives are largely under the umbrella or rubric of that obstetric care. So they're challenged to do what they want to do and what they do best to support mamas toward natural birth. It's like paddling upstream in a hospital environment here.
So then what would your advice be for practitioners who see a lot of pregnant women or pregnant people in their care, and want to sort of help them prepare for for the reality of like what birth would look like when we're doing prenatal visits, where yes, we can check birth blood pressure and supplements and herbal interactions, but there's a whole mental, emotional, knowledge side of preparation that I don't know if people are engaging with completely, but that could really potentially shift the experience for the birthing people that are going in. So what would like the few things that you would sort of offer in terms of like how to focus that in a little bit into your prenatal?
Yeah, so I mean, one, getting educated on prenatal nutrition, because that is such a big piece of what can make a difference in a woman's health, whether
Mhm.
she develops gestational diabetes or prenatal hypertension or other, complications. So having some knowledge of starting with preconception and then perinatal, prenatal nutrition is really important. Understanding the psycho-emotional dynamics that happen in pregnancy, and also understanding those based on different scenarios, right? Whether you're working with a single mom, or whether you're working with a trans man, or whether you're working with a woman who comes from a socioeconomic setting where it's, great to tell her to eat all the great foods in the world, but she's actually getting her groceries at the equivalent of the local 7-Eleven.
Mhm.
So we have to, be aware of who we're working with and how to help those people maximize their resources. Being trauma informed is really important, and being anti-racist informed is really important, particularly for women who have had, whether it was previous birth trauma or whether they've had emotional or sexual trauma. Being trauma informed is really important. And then being anti-racist, right? Women who are coming into our care already carrying the baggage of exposure to racism lifelong. That exposure to racism, not race, but actually exposure to racism,
Mhm.
predisposes to medical complications, but also medical mistreatment. And that combination of a medical complication while somebody's not listening to you is a really dangerous one. And, we saw what happened with Serena Williams. Fortunately,
Mhm.
she's an Amazon and was able to basically advocate for herself, right? But and then I think that becomes the next piece, is really teaching women and empowering women to be empowered for themselves, like giving women permission to speak up against authority, to say, yeah, no, this is not normal, and please stop telling me it's normal when I know it's not, and I need you to investigate. Or, having knowing what birthing women's rights are, pregnant and birthing
Yes.
women's rights are. I posted a post on my Instagram page and on my Facebook page this past week about um, coercion and bullying, and really common things that happen in the medical setting that we just assume are normal and appropriate, like, I'm going to check you,
Mhm.
or meaning I'm going to give you a vaginal exam, not I'm going to give you a vaginal exam. That's like someone saying, I mean, no disrespect, it's like someone saying, I'm going to have sex with you now. It's
Yeah.
different, but it's the same level of invasion of privacy, and we're actually supposed to consent. It's a medical procedure. Or I'm just going to give you a little snip right now when a baby's about to be born and the doctor decides to do an episiotomy. So educating women to understand, and partners also, if a woman has a partner, to understand what some of the language of bullying, coercion, manipulation, and mistreatment are, and that these are legal rights. So probably the best document, ironically, was written by the American College of Obstetricians and Gynecologists, which says something. The fact that they actually had to write a document about these problems tells you how frequent the problems are. And the document, I mean, it's going to be different for you guys in Canada, but it's still a really worthwhile document to understand what is and is not actually acceptable.
Yeah.
And the document talks about what coercive language is, what bullying language is. It also talks about the fact that a woman has the right, a birthing person has the right to make all decisions, not only for their own body, but for their baby's body, and
Yeah.
should never be bullied, threatened, or coerced, or be threatened with social services or your equivalent of social services should a woman decline a therapy that's being recommended, which happens here in the States all the time. Even just like anyone who's curious, go to my Facebook page or my Instagram page and just look at the comments under the post, which it has the word coercion in it. It's from the week of, what are we in, July 27th, this
Yeah.
week.
It was recent. It was this week.
Yeah, depending on when you're watching.
Mhm.
Um,
Oh, right.
so yeah, check that post out, because you'll read women's comments and you're just like, wow. And sometimes women have these experiences and nobody believes them because they seem so outrageous. But
Yeah. And I mean, it's such a good point. Like there's two challenges in that though, because when you're in the moment of birth, and especially like a lot of things come up when you're well, I would say in my experience, at least more often, like closer to like either pushing phase or while you're in the pushing phase. So it's very intense and you're exhausted and there's so much going on. And then the woman is now faced with trying to call out either abuse or like not being consented to. And it's really hard because even mentally you're not there. And so that's
Yeah,
it's another argument for how important a birthing support person is, who's just really there for them and not
absolutely.
worried about anything else, not worried about baby, just like really being there for them. But in all of my experience, it's still very difficult to like, I can coach women as much as I can, but to actually speak up in those moments is really, really hard.
It really is. And
And so,
I would say too, it's not incumbent on everyone who's watching, regardless of what kind of provider they are, to become a prenatal care or birth provider, but
mhm,
to know who is in your community. So know who
yeah,
are the OBs that are going to treat the mom as well, and know who are the ones to not recommend them to, not refer them to.
yeah,
Know who the midwives are, know who the doulas are, know where the good childbirth education is, and know, right now you have to switch to know where that is online. So
yeah,
being, as primary providers, which so many people are who are probably watching, we can't be everything, although I know the demand is often on us to be everything. I just happen to have midwifery and obstetric training. That's what I've chosen to do. But it is incumbent on us to kind of be that hub in the middle of all the spokes to
yeah.
help our patients get, or clients, depending on who's watching, get that care that's really helpful for them and supportive. And that can be, a doula, it can be a prenatal childbirth educator.
Mhm.
Really helping them get lined up with those people is so important.
And then I think also what's important is even if you're not working like in the prenatals field, in your practice, if you are seeing women, to ask them about their birth experiences, to be able
Yes.
to to assess is there trauma, or like just to share with them like that wasn't actually maybe okay, and that's okay that
Yeah.
you feel that way, because that women hold those stories
Yes.
so closely to them because it's a
Sometimes
really
for
powerful.
decades.
Yeah.
Yeah, I mean, most of us, there's a lot of amnesia that happens after birth, and I think that's how we keep having more children, because many women wouldn't otherwise. But there are certain things that happen when we experience a trauma,
Mhm.
and we think about how the HPA axis works, right? The hypothalamic pituitary adrenal axis. It really starts in the amygdala and the hippocampus. And when we're in trauma, we actually have a heightened recall of everything that happens, because that's how our brain catalogs it. I mean, you can blunt it out and dissociate, but really, for women who have experienced trauma in birth, and people are telling them, oh, it probably didn't happen that way, or you probably don't remember it exactly because you were at the height of this, chances are she's actually remembering it exactly right.
Yeah.
Yeah.
I know I was at a birth, just a few weeks ago, actually a month ago. Oh my goodness, time is funny.
Right now it's
Um,
strange.
and it was a midwifery birth in a hospital. And it's actually, so every time the midwife went to touch her body, she said, with your permission, I am going to
Mm,
do this. And then she would wait. And it actually threw me off because of how rare it is to hear that kind of language anymore in so many places. And then her care was transferred into the OB team because there were some complications. And I actually had to take her face and warn her. I was like, they're not going to be gentle with you right now. They're going to get your baby out fast, and it's going to be very different. And um, she said, if you hadn't said that, I think I would have been really traumatized because I wouldn't have been
yeah.
prepared for it. Um,
And
and
even
so
with your permission, I am going to me,
it's
it's still a
not a
little bit
question, it's a
coercive. It's not a
statement.
question, it's a
Yeah.
statement. And it's a statement of, I'm assuming that you're going to say yes. So to me, even that feels, I mean, I'm glad, it's a great experience, but even that to me would be a red flag of a dominator,
Mm-hmm.
as opposed to, here's why I would like to, or here's why I think it would be a really important reason to, how do you feel
Yeah.
about that? May I do that?
And sorry, that was already said. And then she was about like waiting for her to like, and she consented. And then she's like, okay, so with your permission. And she checked
Got it.
again.
Yeah, yeah,
Now
yeah.
I'm going to do it.
That's
And then she's
perfect.
like,
Yeah,
okay, yes. And
yeah,
and it's so yeah, no, that was
yeah,
good.
that works.
Um, Okay, so I mean, we're still kind of living in these COVID times, and
For
there's really not.
sure.
Are support people allowed now in New York, at least?
Yeah, so it was overwhelming. What happened was there was this 500,000 names. It was really interesting because right at the beginning of COVID, for the first time ever, I thought, you know what, I'm going to write an article for the New York Times or an op-ed or letter to the editor or something. And because I was already having patients telling me who, not my birthing patients, but patients I'm doing prenatal care for at a distance, but they're having their baby in another state, not where I live, telling me that they were being faced with this. And so I wrote to the New York Times and said, I've got a letter to the editor. And they were like, this is not going to be a big issue. And then within like 2 weeks, there were probably 10 articles being written by New York Times staff writers that this is happening. And it's really a big deal. But ultimately, there was a lot of pressure, and Cuomo made it a statewide mandate that all birthing partners or one birthing person. So if the birthing person didn't have a partner, she could bring, or they could bring, a doula or a family member that wasn't the baby's biological relation, dad. And they overturned it, although it took about a week before all the hospitals got on board. There were hospital sales saying, yeah, no, we don't have to do that. And it really set a precedent for the fact that women have the right to have a birthing person with them, and that it's not a frivolous thing. It's not just emotional need. And even if it were, I mean, that should be good enough, but that there's actually a health precedent for doing this.
Yeah, and I mean, again, it's an interesting example of the way women specifically in a lot of healthcare, their rights are just sort of like their type of care can sometimes be
Yeah,
pushed away a little bit. Like it's not important. Like
yeah.
there's nurses there, you'll be fine.
Exactly. And the thing is,
And
the nurses were giving pushback because they're like, we don't want to be exposed and we'll take care of the mamas. But they
yeah,
were the only people and they couldn't be in the rooms enough. And so, one of the things that we were saying is if you're going to be in the room the whole time with someone who has COVID, you're going to have more exposure than if you just
hmm
basically stay out of the room and let the support person be in there.
yeah,
But yeah, it's just hugely complicated situation. And I mean, it doesn't change the fact that obstetric injustices are still happening. We've had 3 maternal deaths of Black women in New York just since March. And in New York, Black women have 12 times the mortality rate of white women in some hospitals. It's just a really difficult time, and it's been a difficult time for a really long time. And the C-section rate in the United States, when I started out studying midwifery in 1981, the C-section rate at that time had escalated to 19%, and that was considered outrageous. There was actually a big like white paper that had been published at that time called Unnecessary Cesarean, and now we're up to about 34%.
yeah,
And that's average. So some hospitals are a little bit lower, but some hospitals are astronomically higher. And we know that C-section puts moms at way more risk. And it's really complicated too, because as women, for decades, we've been fed how dangerous birth is.
yeah,
And so, it's really hard. I mean, one of the things I'm just adamant about is never blaming mamas. I don't want any mama, if she has a C-section, an intervention, whatever, necessary or not, it's not her fault. We're all going to do what we think is best for our baby in the moment. And if someone is telling you, you need this intervention, I mean, you'd be like, cut my arm off to save my baby if that's what you had
yes,
to do, right?
yeah,
So that's the challenge, is changing a system in which a third of all women have had this intervention, and you don't want to make the women wrong. And at the same time, we have to address what's actually happening, because the World Health Organization says that over 17% C-section rate actually becomes a liability to mom and baby. So up to 17% is an acceptable amount given the range of complications and various things that contribute to more challenging birth outcomes or more challenging births. But anything above that increases mom's risk and increases baby's risk. So we're double that.
yeah. Have you like, are there things that you have found either in prenatal care or like during labor that actively reduce women's risk of getting C-sections that you educate your prenatal
Yeah.
clients on?
Staying at home, staying out of the hospital as much as possible, for real, is one. But that's not for everybody, right? And so having probably the biggest thing you can do is have a doula.
Yeah.
And have a doula who's comfortable advocating, who's trained in trauma work, who's trained in advocacy, and have a doula that resonates with you.
Yes.
That may be, as a Black woman, having a Black doula. It may not be. But if that's going to be relevant and important for you, have that doula that really resonates. And it may not be a racial or gender resonance. It may just be like, you feel copacetic with me. I can talk with you. I feel trust with you. I feel confident with you. And that becomes the most important thing. But having a doula with you can reduce your C-section risk by 20%. So that's a huge amount. And then from there, I mean, as much as you can be as healthy as you can during pregnancy, stay active, avoid the things that, medically increase C-section risk, avoid interventions that increase C-section risk. So, staying at home as long as possible, not going into the hospital too early, not being induced if your body's not ready to be induced. There are things we can do, like a Bishop's score, which is a simple set of physical exam parameters, and that can be done to see, is this person ready for an induction? So there are lots of little things like that. And then psychologically, just helping women get really prepped for, you don't want to scare people, but birth is an intense experience. I mean, you're not going to climb Kilimanjaro and not know that
Not trained.
Can be like, right, yeah, you can get brain edema and not be able to think if you get too high at altitude, right? So we want to know what the rigors are. Nobody's going to climb Kilimanjaro without having done a lot of hiking and practice. So we can't really do that for birth, because you can hike a local mountain, but you can't do labor practice, right? But trying to really have a lot of tools on hand, movement, physical support, herbs, meditation, hypnobirthing, whatever it is, have a tool bag. I think of it like Mary Poppins, that tool bag you can keep her bag that you can just keep reaching into, pull out a lamp, pull out whatever.
Yeah.
And have somebody there who can remind you, ideally, of what those tools are when you're in the throes of it. And especially if you're in the throes of it and you've got an environment where people are pathologizing you.
Yeah. And I think as practitioners, I think your point is like finding the resources to be able to lead, like make a handout or something and have that list and like kind of like, oh, you're pregnant, here you go, because there's so much, even if you've had a baby before, right? Like all of these things can kind of continually come up again. I really struggle with the line of like scaring my clients versus preparing them for what it's going to be like, because a lot of women really want to attempt to have a natural birth, and I love that. I love supporting it, and I think it's great. But I really do need them to know that it's going to feel intense. Like there's going to be an intensity that they're going to feel, and they're like, "Oh, I'll be fine," and then they get there like, "I can't do this." It's like, no, we've talked about this. This is like your 4 centimeters. Like it's going to keep going, and but to like also talk about the I don't know what the word is, the high after the birth when you go through that natural birth, and like that you've done it is a pretty substantial, like it's like climbing the mountain.
Yeah, it's funny. I was talking with one of my best friends. She was my midwife teacher, and she's a midwife in the South. She trained me. We've been at each other's grandchildren's birth, and we were just chatting the other night, and she's kind of the next generation of Southern Black midwives. She's in a really interesting position. She was telling me this, and it's relevant because she was being interviewed by the National Association of Black Midwives, and they're doing a documentary on this legacy. And so Saran Henderson is her name. She's got an organization online called Birth and the Tradition. She's a phenomenal woman. And she was saying how what she sees different from like the old grand midwives who attended mamas in the South to the generation of mamas and next generations that she's attending now is that, 50, 60 years ago, you walked a couple of miles maybe in the South to go to the general store. You squatted in the field or while you were cooking or while you were down playing with your children. And women were just had more like grit, and pain was an expected part of life. You couldn't just get a pain medication. And so women went into the experience more prepared for an experience of hard work and more psychologically comfortable with the idea of hard work. And I think a lot of us don't grow up comfortable with things being hard. And when they're hard, we find help or we find a solution, or when they're painful, we take a medication. And there's nothing wrong with that. Again, I mean, a well-placed epidural can work wonders for a difficult labor. C-sections are lifesavers. But there's a lot of room between going into labor and when those things happen. And so part of it is, this is really hard, and that's okay. That's normal. And what can we do to make you more comfortable? What can we do to help shift your mindset? What can we do if there's something that's making it hard, baby's position, or, you know, but it is hard, and it's always been hard. And, you know, how do we embrace that as okay? I had a birth once where I had transported from home to hospital with the mama, and it was a long labor, but she didn't want an epidural, and she was doing fine. She just felt it was just time. There were things going on. It was time to go to the hospital. And the nurse must have come in every 30 minutes. Do you want an epidural? Honey, if you don't get an epidural now, the anesthesiologist is leaving. Like, every trick in the book. Finally, I just looked at the nurse and I said, look, my name is Epi. And I pointed to my apprentice and I said, her name's Dural. So she's got an epidural. She's all good. And the mom laughed and the nurse left with like a hump. But, you know, but on the other hand, I've gone to hospital and said, let's get the epidural. It's going to really probably help you relax and dilate. So knowing what that kind of spectrum is, but not, we just jump into the deep end with the epidural or the C-section. And that's not necessarily always optimal.
Yep, totally. And there's very few, there are very few examples in our life where we are asked to move towards pain, right? Like it's so not like we take care of our kids right away, like pain, you know, we kiss it away, whatever. And so I find birth is so much, it's almost more of the mental marathon than anything, is like to like be able to like get past your mind and doing so.
And I think too, how we're raised around birth. Like for me, right? My mom, she was like this feminist young mom. And so the story that I grew up with was that she was out playing softball in the neighborhood when she was pregnant with me. She went into labor. She had me 3 hours later. She had my brother in 4 hours. So the story that I grew up with was that birth is, hey, you can play softball and then go have your baby, right?
Yeah.
So if you grow up with stories that birth is dangerous, because maybe it was for women in your family, or the cultural messaging that we get around birth and the messages that OBs reinforce. I mean, just to give you an example, this is such a blatant example, but I was pregnant with my first baby. We were living in Vermont, but we moved down to Atlanta, where my husband is from. And because it was like 4 feet of snow on the ground in Vermont and 75 degrees in January in Atlanta, we're like, this is good. And I was starting to apprentice with some midwives then. And my mother-in-law said, oh, call Dr. Spanier, because even though you're having a home birth, you should have an OB check you out. And I called out of respect. He had delivered my husband, my sister-in-laws, my brother-in-law. I went on to deliver all the other kids in the family who weren't born at home with me, because there were some of those that were born at home with me or other people. I called Dr. Spanier. And he said, oh, you know, very nice to meet you. Where are you having the baby? I said, oh, I'm having a home birth. And he said, you could just like hear the voice change, you know, like Dr. Jekyll, Mr. Hyde. He's like, I will never forget these words. This is exactly what he said. I wouldn't touch you with a 10-foot pole. Pregnant women are a disaster waiting to happen. And I was like, basically, F you very much. Yeah, no, I won't be needing your help. Thank you. And that was it. But those words were just, and the thing is, for me, I was such a little radical, you know, earthy mama that I was just like, well, I'm not going to talk to him again. But I've had women who were literally crowning their baby at home, who an OB had said something like, looking at the partner and looking at her like, you're never going to get that baby out. in the second trimester said that to her. And then literally the baby's like a half a push away and everything stopped. And the woman look at me and say, am I too small to get the baby out? Is the baby, is this a problem? Am I going to need a C-section? I'm like, no, baby, like baby, that like how you're in that heightened emotional state, but those little seeds of doubt can linger. And if we're kind of breastfed on those our whole lives by our culture, or bottle fed on those our whole lives, it's hard to shake those off.
Mm-hmm.
And so I think, for me, I saw birth more as a journey, a spiritual quest, and that's not for everyone. And a lot of people will need to birth in the hospital for medical reasons, or it's their safer place. But how can we reframe birth from the medicalization that we've all internalized about it, and not letting go that there are medical things that happen, but reclaiming our, it was like, what would we do if every time a woman was about to have her period, like somebody brought 3 units of blood to her house in case she hemorrhaged out, or like, so like, let's strap you to a monitor because you could die. I mean, obviously the stakes of birth are different than having our periods, but everything is so medicalized that we don't realize this can actually be a normal part of life.
Mm-hmm.
And when we go into it that way, we actually, interestingly, also often keep our risks lower. So there are studies, for example, that have shown that women who are already at higher risk of becoming high risk, so women who have nutritional, food
Mm-hmm.
access, socioeconomic issues, etc., if they go to OB care, they're more likely to become high risk. If they go and have a doula and a midwife, they're more likely to either stay in a lower risk or even reduce their risk of high blood pressure, preeclampsia, complicated births, preterm labor. It's fascinating.
It
So
is.
actually how we think about it and approach it. And I
Yeah.
think that's so important as providers, because the language that we use, the way we communicate, the stories that we're sharing can really scare or support a woman who's pregnant, a person who's pregnant, and her partner too.
Yeah. And the majority of my patients who are pregnant often come through fertility, and so then they come into that, and so the first, when they're like, I'm pregnant, I'm like, fantastic, let's talk about the differences between a midwife and an OB, because now
Yeah.
now we're here, right? And it's these sorts of conversations that I think are important. There's I will try and find it as a resource for all of you, but there's I'm so sorry, I can't remember your name because I'm terrible with names, but somebody created a course for, it was for naturopathic doctors. It was for people who aren't OBs or midwives, like who just sort of see pregnant women in their care, and created like one topic to talk about every month in terms of like the prenatal care, so that you kind
I
of
love
cover a whole
that.
bunch of things to help guide you in terms of, so if you do work with a lot of pregnant patients, then it'd be a great kind of course or resource to look at. Can you speak? I know there's a few questions, so I want to make sure that we have a time for those, but
Yeah,
can
and
you?
I just want to quickly say, if you don't mind,
No.
toward that, in the US at least, the first postpartum visit is not until a woman is 6 or 8 weeks pregnant postpartum.
Get out of
And
town.
no, that's when insurance starts to cover postpartum. So unless you've had a medical reason to go back to the OB, like your C-section scar incision opens or something, you don't get it. You don't get that postpartum care. So if you aren't a person who takes care of mamas, but you take care of children, you will be the frontline person to be asking how it's going postpartum for mama.
Yes.
How's breastfeeding going? How are you feeling? Which you can legitimately do, because mama's well-being is going to influence babies. So keep that in mind. Okay, sorry, I just wanted to make sure to say that.
No,
Questions?
thank you. And we don't have enough time to get into even the postpartum support for moms,
Yeah.
but like also like, because the isolation that's happening now is, I think, a
Yeah,
challenge for a lot of
it is.
people.
That's why we're doing so much postpartum support that's why we have the weekly support group. We
Yeah.
have postpartum mamas in there. And that's another thing too, if you're not familiar with postpartum, this week I also did a post on postpartum. So there's the post on coercion, and then the next one after that is on postpartum. And what I asked women to do was share one tip that they thought was so important that they wish they had known, or wish they had done, or would have advised another mama to do. And so on my Facebook page and on Instagram, you can read, dozens of beautiful comments, but that will give you insight into that postpartum time as a provider.
I just wanted to, I think a lot of practitioners are going to be getting questions from their patients, just asking like, how concerned should they be as a pregnant person and getting COVID, or
Mhm.
like their risk of that? Is there anything that that from your research that you can comment on quickly on?
Yeah, and so, for those of you who are interested, there's a blog on my website and a corresponding podcast just about COVID and pregnancy. And then there's on my Instagram, if you go to my IGTV, there's an Instagram from a few weeks ago with me and a gentleman named Neil Shaw. Neil is an OB in the US. He's trained by Atul Gawande. He's like his protege. He's brilliant. And he's one of the leading advocates in the obstetrics world for reducing C-section. And we specifically talk about the risks of COVID in pregnancy and birth. In a nutshell, so far, all the data that's coming in is there may be some small risk. There's been actually a decrease in preterm births for unknown reasons.
Yes, I know
A very small possible risk in stillbirth, but unclear whether that's actually COVID related or the fact that women are getting less prenatal care, not seeing their doctors and staying home with complications that needed medical attention. But overall, the good news has been pregnant women do seem less susceptible to developing COVID and less susceptible to developing severe symptoms from COVID and unlikely to pass it on to babies. So caution is definitely warranted, but it seems to be overall generally reassuring compared to the general population. Now, of course, if you have a woman who already has risks, she is in a population that is already at more risk for COVID and already at more risk for having comorbidities. So a Black pregnant woman who has high blood pressure and asthma is still going to have high risk. So that's where we want to not forget that there are certain factors that individually will increase a woman's risk.
Yeah, awesome.
Of COVID as well. Yeah.
So there's just a few questions, but I'm going to answer 5 of them in one sentence.
Okay.
So the hashtag that everyone's asking about is hashtag I deserve birth support.
Yes.
There's a lot of questions about references for the paper that we talked about from the American College and other resources for pregnant women.
They're actually on that page. So if you go to hashtag I deserve birth support on Instagram, you'll get to all the lovely pictures and stories. If you go to hashtag I deserve birth support on Facebook, you will get to the course page. In the place where you can put attachments and have like categories and topics, there's a category on advocacy, and you'll find the download there. But it's called the ACOG. Just look up ACOG, ACOG, informed refusal, and that will get you to the document on Google as well, Google search.
Yeah,
and then you also have we have the PDF right on the course page.
Yeah, exactly. You've got that whole page where there's tons of resources for for the video of positions and essential oils and herbs, and so it's a huge amount of resources there for you. And then I just wanted to share another resource that I've been using for like my own education as a practitioner. Evidence-based birth has, if you go to evidencebasedbirth.com, I mean, there's a ton of information there just looking at the evidence so that you can help advocate for or just giving informed consent around certain practices. But they have one called evidencebasedbirth.com/birthjustice. And it goes through the Black Bill Birthing of Rights. It has Instagram tags or accounts to follow that are really great advocates. There's podcasts, there's articles. To really just inform yourself of the
and there's some other resources as well. I would say Sifter Song is a really important reproductive justice and birth justice. And then Every Mother Counts is actually doing a really great job with birth justice, but also COVID resources. But I agree, evidence-based birth is a good one too.
Yeah, and I think a lot of those are listed on her page as a resource to sort of connect into. So that question answered that. That question answers that. Someone's asking, what's the best way to search and find a doula? And I don't know if you're in Canada or the US. In Canada, Google it.
Yeah, US too. There's so many associations. Yeah,
doula and blank space of where you live is your best way. And then just sort of email and call. Doulas really try and make it easy for you to find them. So it shouldn't be terribly hard. And then I do suggest interviewing a few to connect with somebody.
Yeah, and ask around in your community, if you know people who have used doulas.
Okay, we got that one, we got that one, we got that one. If you plan on having a home birth and for some reason a C-section is needed, is this something either of you has seen before, or is this common?
Yeah, definitely.
Yeah,
So
sure.
the transport rate from home birth for a first-time mom is as high as 20%. The transport rate after that is usually pretty low, down in the single-digit percentages. But C-sections can happen whether you're planning a home birth or hospital birth. Usually with home birth, we don't usually see that much need for like an urgent emergency C-section. It's usually things are taking a really long time. There's some reason that the baby's not moving down. There's a position issue, and we go to the hospital, try different medical techniques, sometimes induction or augmentation, sometimes an epidural, but sometimes a C-section is needed. And the rates of complications of actually for mom at home and the need for C-section goes way down. The maternal mortality and morbidity for women who have babies at home is actually less than in the hospital. But most midwives are pretty good at anticipating complications and are able to make that transfer of care in a timely way before it's too late, before it's even anywhere near too late.
Yeah, no, yes. And then the last question here that, so this person was asking, Michelle, any advice for becoming trauma-informed as well as anti-racism informed in terms of resources? So you gave some great advice for anti-racism, but any specific resources for trauma-informed?
Yeah, there are quite a few books on trauma-informed birth that are great, but offhand, I mean, I've got like 10 titles upstairs in my office, but offhand, they all have trauma and informed in. So I would kind of do the same thing, Google. There is an organization in the UK that is doing trauma-informed work, and then there is a woman named Billie Harrigan, Billie Harrigan, Harrigan, and she's actually in Canada, and she is a trauma-informed educator. Yeah, we did a one of the classes on my course together, actually.
Awesome.
Yeah.
Awesome. Well, it is 4 o'clock, so we are going to end here, everyone. I know we again, we could have talked about this forever. We didn't even dive into the challenges of our fertility patients and what they've been experiencing through COVID because of the halt of things. And so that is, I wanted to acknowledge that, and I'm sorry if that's something that you were hoping to discuss. But we'll just have to talk again another time as needed.
It's similar. Everything had shut down for a while, but a lot of facilities are back up and running just with precautions. I know people have patients who are going in for fertility care. So, I mean, it seems to be back online, and it's more about the concerns that someone might have about choosing to have a baby right now.
Yes, and also just again pointing to like the best way that we can support all of our patients is by being there for their mental and emotional support, offering and asking questions, and checking in, making sure they're okay, and supporting them through the emotional toll of either the wait or the change in care that they're experiencing.
Yeah,
so
the isolation.
Being informed so that you can continually support and be ahead of a few steps ahead so that you can kind of meet them where they're at. Yeah.
Thanks for having me.
Yes, thank you so much. It was lovely to see you. We will be again here for the third and final installment on September 3rd. We'll be talking about children's health and resilience and helping kind of moving into this fall season and how we can do that for our practitioners and our as practitioners for our parents and our kids. So we'll see you in September. Have a lovely long weekend, everybody.
Bye, everyone. Yeah, in Canada. Bye, everyone.